Joining us today. We're so excited you could tune in to CCRM's first quarterly interactive webinar. Dr. Eric Suri is Medical Director here at CCRM and will be conducting today's presentation. We do encourage you to type in questions for him as we go along. We have also a pop quiz poll that will be ready here shortly. The tab is in the top right side of your screen to access. And we'll review results of the poll and address questions at the end of the presentation. And with that, I will now hand it over to Dr. Suri.
Well, thank you, Kelly. It's really a pleasure to be able to do this as sort of an experiment. And this is really our way of trying to thank all of those who have supported us in the past, and we look forward to a long and productive relationship in the future. We've tried to give back to the community as best that we can, and we've used the one-day or half-day conferences before, and we thought we would try a new technique, which is this webinar, and we hope to do these on a quarterly basis. We very much appreciate any interaction that you have, that you can give for us, given that this is new. And so we appreciate your input, and let me get on with the introduction and with the talk that we'll do today. But as Kelly had mentioned, I'd very much like you to type in all your questions. I'll answer them all at the end. If for some reason we have more questions than we can answer, we will absolutely respond by email. So I'm looking forward to this and to your input as well. So at this stage, what I'd like to talk about today is what's been sort of a complex subject, which is ovarian reserve testing, and what does it really mean? And unfortunately, it's not going to be quite as straightforward as we would like, which is why I get to talk to you for a little longer. So we first have to ask the basic question: what are the real goals, and does the testing that we currently offer accomplish those goals? Is it to predict the chance of pregnancy, the chance of live birth? Is it from assisted technologies? Is it from controlled hyperstimulation such as a Clomid cycle, or just natural pregnancy rates? Then the question comes, is it dependent or independent of age? Meaning, is a woman with an abnormal test result who's 28 in the same situation as a woman who's 43 with that same test result? Or does it predict something much more basic, which is how responsive or sensitive a woman would be to the various drugs we use for stimulation? So clearly the ideal ovarian reserve test would predict both the response to stimulation and the chance of a live birth, which is a great goal. Unfortunately, what has really been shown is that the predictive properties of the tests that are currently available are really modest at best, and it's really not as sufficient as we would like. We would hope that we'd have a single test that would predict pregnancy or not. It just doesn't exist. But I would say the key point of this whole talk is that age trumps all. Age is the most important piece of this puzzle. So when we look at what's available for testing, the first three are fairly simple things to achieve, which is finding out your patient's age. And I would guess her past history as well. And then there are fairly simple biochemical tests, such as the FSH level, the estradiol level, anti-Mullerian hormone, or AMH, and inhibin B. There are dynamic tests, such as the clomiphene challenge test, which we'll also talk about. And then two other dynamic tests, which really aren't used very much anymore, the GAST and the FORT test. And then there's ultrasound capability, antral follicle count, and an evaluation of ovarian volume. So I just want to give you a quick reminder of some basics about statistics, just in case you weren't paying attention that day in class or taking a nap, as many people often will do. The first issue is the sensitivity. Sensitivity is just the chance that a test will categorize someone who has a disease as being positive. In other words, if the test is positive, they truly have the problem. The second is specificity, which is the chance that a test shows that a person does not have the disease and the test is negative. So in other words, a negative test result means the person doesn't have a problem. Then there's a ROC curve, and this is just a plot of sensitivity and specificity of various tests, and the results are calculated as an area under the curve. Now here's a key point. How do you set normal or abnormals? Well, if you change a cutoff point to optimize the sensitivity, that's going to mean you're going to have less false positives, but more false negatives. If you change a cutoff point for what is or isn't normal to optimize the specificity, you're going to have less false positives, but more false negatives. So let's get to the first and basic piece, which is the issue of age and fertility. This is an older study, but a key study that came from the Boston IVF group that looked at over 20 years worth of clomiphene therapy and intrauterine insemination for couples with unexplained infertility. And you can see here a significant decline in pregnancy rates with the same therapy based on maternal age, so that for women 42 and older, there was only a 1% pregnancy rate. When we look at, looking at the CDC, which reports outcomes for IVF, and this is older data from 2007, but the principles are the same, you can see in the red a significant decline in pregnancy rates and an increase in miscarriage rates with increasing maternal age. And it looks like the cusp here is around age 37. And interestingly enough, that's the age that correlates with an increased incidence of aneuploid or chromosomally abnormal embryos as well. Now, does paternal age play a role? And this is a little less clear. In this review from 2011 of 10 studies, it suggested that there wasn't really a clear correlation between increasing paternal age and outcomes from in vitro fertilization, such as fertilization, implantation, pregnancy, live birth rates. But what is interesting is that as embryos were allowed to develop further in the laboratory to the so-called blastocyst stage, there is a decrease in development, which may reflect a little bit of the genomic activation from the male. The classic test for ovarian reserve is the baseline FSH level, which is typically performed on days 2, 3, or 4, ideally day 3 of the cycle. And it is important that the patient record what her true day 1 is. Spotting should not be included. Day 1 to be the first day of true bleeding. Now, the FSH level tends to go up with advancing age. An increasing FSH level leads to more rapid follicular depletion, a further rise in FSH. And I guess I'm seeing a note here that says that folks can't see the slides. So hopefully that's being fixed. So hang on just a second while we fix this. We're working hard. Hang in there. Okay, hopefully this is working now. And I'll just continue on, and if you can't see the slides, please just do type back in. So going back to the FSH level, these levels tend to increase with advancing age. As the FSH goes up, that stimulates the ovary to deplete follicles more rapidly. The net feedback is the FSH goes even higher. Here's the problem. You can't do an FSH level without having an estradiol level. I often will have patients who are older and they've been told by their doctor your FSH level was 4 and you're 48 years old. The problem is they didn't look at estradiol, because remember, as the FSH goes up, it drives the ovary to produce more estrogen. That then feeds back to the brain to lower the FSH level. And when you look at variability by cycle day, we can see that the FSH level really doesn't vary very much for the first 4 days of the cycle, or for all the way up to day 5. But you can see on this slide that by day 5, the estradiol level does rise rather significantly. And I'm getting words that we still can't see the slides. So we're going to try to fix this again. Okay. Hopefully we've got this work now. So again, just feedback with me. And if we end up having long-term problems, we'll fix this by getting this all out to you as a taped version. But if you hopefully can see the slide here, the estradiol level begins to go up after day 3 in any natural cycle, which makes the results less interpretable. And that's why we really recommend testing be done on day 2 or 3. This is the classic study that looked at the relationship between pregnancy rates and FSH levels that came from Norfolk, Virginia, and this was way back in 1991, that showed that as FSH levels rose, the pregnancy rates and delivery rates significantly declined. The cycle cancellation rates went up. And this was using a cutoff level of FSH of 20. Now, since that time, the way in which FSH is measured has changed dramatically. We also have the question of what happens in patients who have FSH levels that vary from cycle to cycle. There's always been this thought of if it's abnormal 1 month, let's just wait till the next month when it's normal and then pounce. Unfortunately, that's not been shown to be very helpful. And you can see from this study, which again goes back to the mid-90s, that pregnancy rates were significantly higher. It is kind of interesting to see a good pregnancy rate was about 17% back then from IVF. But that if all the tests were normal, the pregnancy rates were dramatically higher than those that had one abnormal only, and even higher than those that had all abnormal. So even one abnormal FSH level represents a significant compromise in the ability to achieve a conception. So the theory is you really need to buy into the worst result that you have. The other question is, does age play a role independent of the FSH levels? And this is a rather complex slide, so I won't go through every piece with you, but the bottom line is when the FSH level was higher, particularly in younger patients, the net result was that less eggs were retrieved and that there were higher cancellation rates, but those that actually got to the point of having embryos replaced had the exact same pregnancy rates. So it was a predictor more of response than it was of outcome. So here's a patient that comes in and says, hey, my FSH level is normal. Well, this gets back to the point of the estradiol levels, because the likelihood that this young lady is going to get pregnant in the near future is not very high. And so when we look at the predictive value in older populations, this was a study that was done in 2005 and looked at women in their 40s. And it said, yes, the FSH level did correlate with pregnancy rates, but age still became the most important piece. The highest level that they recorded with a live birth was 15.4. I understand we're still having some technical difficulties, and we're going to try one more thing, so hang in there. they did all the trial runs with the rockets before they went to the moon. So, so as I was suggesting from the slide, you hopefully can now see that the highest live birth rate for an older woman was still at 15.4. And so the question is, what's a better predictor, age or the FSH level? And as you can see from this study, or hopefully you can see from this study, looking over 1,000 women, that age was still a better predictor than FSH, because in the yellow are women who had FSH levels less than 10, and the red or burgundy are women who had FSH levels greater than 10. And in each age group, women with normal FSH levels had higher pregnancy rates than women with abnormal FSH levels. But women who were younger had much higher pregnancy rates than women who were older. So the FSH is still dependent on age as well. It's not a purely independent predictor. So that leads to the question, is it better to be young with an elevated FSH level or old with a normal FSH level? And I think this slide here will suggest that women who were under 41 with higher FSH levels had significantly higher pregnancy rates and implantation rates than women who were older with normal FSH levels. So once again, age trumps all. The next question is, what happens if a woman has had an ovary removed or has had significant ovarian surgery, which we won't touch on today? It has more to do with the endometriosis piece. But this looked at women who had one ovary removed versus controls, and the FSH levels were higher in that age group. So that doesn't mean necessarily their pregnancy rates are lower, but we would anticipate that there would be lower pregnancies, lower number of eggs retrieved or eggs available in that group. We looked at our own statistics based on FSH levels and looked at the level itself, which is on the top bar here, and the likelihood of pregnancy or implantation. And women who had low FSH levels did have higher implantation rates than those with higher FSH levels, but we still were able to achieve pregnancy in, granted, a smaller number of patients, but who had high FSH levels. So one should not preclude these patients from undergoing therapy. It doesn't mean that all bets are off. It means that their likelihood of conception is going to be significantly lower than other women their age. So this was a meta-analysis back from 2003 that looked at 21 studies, and it basically said the FSH level had a moderate predictive value for a poor response, but a very poor predictive value for women not getting pregnant. And it's kind of helpful when it's very extreme. If a woman has an FSH level of 30, clearly her likelihood of conception is significantly compromised. And the recommendation from this study with the basal FSH level should not be a routine test to predict IVF outcome. It does predict general fertility, but it should not be a triage for whether someone should or should not go through therapy. So what are the barriers to accuracy? Every lab is different, which is why we tend to repeat our levels here in our own laboratory. What's a normal? Well, back the older studies, FSH of 25 was abnormal, but that's now changed. The new standard is that an FSH of 25 now is an FSH of 16 or 17. So our normal cutoff tends to be around 10. Bad numbers would be over 15. The other key point about all this testing is all the data comes from infertility patients. We have almost no information on the general population. The other critical piece is the failure to evaluate estradiol levels, as we'll talk about in just a moment. And then there are some issues with younger patients where a high FSH level may have nothing to do with fertility, but various other isotypes of FSH that are being picked up by the assay. So let's look at the estradiol level. This is an older study which was very interesting in that it suggested that women who had high estradiol levels, independent of the FSH, had significantly lower pregnancy rates. So these are women with high estradiols in the dark blue and normal estradiol levels in the light blue. They excluded women with polycystic ovary syndrome. Another study from the 90s suggested that women with normal FSH levels who then also had high estradiol levels seemed to have lower pregnancy rates as well. But this at least controlled for the FSH. The problem with estradiol levels is it has a virtually useless predictive accuracy when used by itself. So don't just draw an estradiol level. There isn't really a standardization of threshold levels, and there's a lot of variability from cycle to cycle. There was an excellent guideline published by the American Society for Reproductive Medicine in 2012 that very clearly stated, and I would just quote this, that basal estradiol alone should not be used to screen for diminished ovarian reserve. The test has value only as an aid to correct interpretation of a normal basal FSH levels. In other words, it helps you interpret the FSH. It's not helpful by itself. Now, the clomiphene citrate challenge test, or Clomid challenge test, was actually first described in the late 80s. And the concept behind this is the way that Clomid works is that it has an anti-estrogen effect. And so if it has an anti-estrogen effect, it blocks receptors in the hypothalamus and pituitary, and FSH levels classically go up, as do LH levels after dosing. The way the test was described is that you obtain basal FSH and estradiol levels on day 3, administer clomiphene at 100 milligram doses day 5 through 9, and then repeat the level on day 10. Poor prognostic result would be either an FSH level over 15 on either day 3 or 10, the sum of day 3 and day 10 being greater than 26, which is almost the same thing, or others have said greater than 22. So this is the way a clomiphene challenge test should look, and you can see a normal result is with the orange bars where the FSH level should quickly go up and then rapidly drop. So if you sample before day 10, you're going to get an elevated FSH level. With an abnormal result, the level will go up and stay elevated. Now, how does this correlate with outcomes? Well, the studies from the mid-90s would suggest that the abnormal clomiphene challenge tests were very much correlated with poor IVF cycle outcomes, normal results being in blue and then abnormal in purple. And again, age still trumped all, because younger women with normal clomiphene challenge tests had much better responses than older women with clomiphene challenge tests. How helpful is this in older women and women over 40? Well, this is a study from 2000 that showed that women who had abnormal test results with an FSH level over 11 on day 3 or over 13 on day 10, they had no conceptions whatsoever in this study population. Then is it helpful in younger patients? Well, not quite as much, because you can see here, looking at women who are under 40, the delivery rate certainly dropped off with abnormal test results, and there was a predictive value, but they still had pregnancies in these patients, just at lower rates. So again, this is not someone whom you'd want to preclude therapy, but it's someone you may want to move along more rapidly towards more aggressive treatments, and someone who should be aware of their overall prognosis, but their prognosis is not necessarily 0. So there have been some studies that have compared the simple day 3 blood work to the clomiphene challenge test. The problem is it's hard to combine these studies because they're all very different in the way they're designed. Half of the studies compared the techniques. So in terms of predicting a poor response, clomiphene challenge test is a little more sensitive than day 3 FSH. In terms of predicting people who wouldn't get pregnant, a little more sensitive as well. The conclusion was there was a slight additional value, but not great additional value. And this is a little different than what I would have recommended to you 5 or 6 years ago when we were strongly recommending clomiphene challenge tests. I don't usually perform these very much anymore. This is a meta-analysis done in 2004, again, which showed that both the day 3 FSH and the Clomid challenge had a similar ability to predict clinical pregnancy, but a normal test for either is not particularly useful. It's the abnormal test that's highly predictive for women who don't get pregnant. Then we move on to visual testing. One is the antral follicle count. This is an ultrasound exam that should ideally be performed in the early part of a cycle, and what you're measuring are smaller follicles that are 2 to 8 millimeters in diameter. Remember, every month the woman has a small pool of eggs that are available for use in a given month, and then one is released and another group of eggs comes along. A normal result ideally is over 10 in both ovaries together. Less than 4 to 6 seems to increase the likelihood of cycle cancellation or poor response. there's not a lot of good data looking at antral follicle counts outside of the IVF world. But here's a paper from Fraterelli and colleagues that looked at pregnancy rates based on the number of antral follicles, and you can see in the purple significantly higher pregnancy rates in women who had more than 4 antral follicles than those in blue who had less than 4 antral follicles. There is some variability from one cycle to another. There's less variability than using FSH levels or ovarian volume, but you do have to remember there is some change from cycle to cycle. It clearly changes with age. There was a nice paper that came out in the late 90s that suggested that the antral follicle count decreased by about 5% a year in women under 37 and then accelerated in women over 37 to about 12% per year. So this is why it's very critical not to rely on data that is several years old. The fact that a woman may be only 35 and had normal test results at 33 does not mean that it's still normal at 35. I would recommend in women under 40 having this testing done at least on an annual basis. There is a nomogram that was created in premenopausal women, and this group in the second study calculated that for every year increase in age, the antral follicle count decreased by 0.4, and they were able to actually try to predict when menopause would occur based on antral follicle counts. What's the clinical relevance? Well, it did seem to be very helpful in predicting ovarian response and cancellation rates, but once again, the same theme here. The antral follicle count did not predict implantation, pregnancy, or live birth rates. This is what our goal was in doing this testing, but there is a secondary benefit in seeing how patients will respond to medications. Inhibin B is often included in some of the fertility assessment assays, and this is a protein that's secreted by the granulosa cells, seems to peak in the mid-follicular phase. The initial studies recommended that it be tested in the early part of the cycle, day 2 through 4. Early studies suggested that it would be a good predictor of cancellation, and pregnancy rates may be a better predictor than age. Levels less than 35 to 45 are thought to be abnormal, and it was thought that this would be more sensitive, that the inhibin would change before FSH change. And this was based on 2 papers from the late 90s by Seifer and colleagues. This group had looked at inhibin levels and IVF cycle outcome and showed that as levels were higher, as you see in green, the pregnancy rates were significantly higher, miscarriage rates were significantly lower. And this is very encouraging, but there are problems. There are huge variabilities amongst the assays in terms of results, so that sending from one lab to another were not very reproducible. Studies have shown that both age and FSH were more predictable for outcome, that inhibin B did not correlate with pregnancy, was felt to be less predictive than the Cloma Challenge. And once again, this guideline that was practice guideline that was published by the ASRM in 2012 very clearly stated that inhibin B is not a reliable measure of ovarian reserve and it should be abandoned. We do not use this testing at all. I do not recommend it. A critical addition to our armamentarium has been looking at AMH, or anti-Mullerian hormone. In Europe, this is called Mullerian inhibitory substance, or MIS. You'll see that in some of the papers from overseas. It's a glycoprotein, and for what it's worth, it's in the TGF-beta family. This is expressed specifically by granulosa cells of the preantral and antral follicles. The levels are not dependent on when you draw this in the menstrual cycle, so this makes it a lot easier. You can just see a patient in your office and have them evaluated just at that first visit. There is a decrease in value by 0.2 nanograms per mil through age 40, and then by 0.1 nanograms per mil thereafter. There seems to be a lot less intracycle variability than the antral follicle count. Now, there had been 2 assays used, and most people don't get into this when they're ordering tests. It's sort of the Beckman versus the DSL, and why would you care about this? The reason you would care is the results were very different, and there's no conversion factor. Now, most assays now have been replaced, and there is a single assay being used, but it is important that the lab you use, that you be aware of what assay is being used. So if you're going to send off AMH levels, just make sure you know what the assay is and what normal results are. So what does it predict? it was felt to be highly discriminatory for clinical pregnancy in early studies. And this is a study from France by Hazou and colleagues that suggested that levels 2.4 and over were highly predictive of pregnancy and less than 1.1 predictive for not achieving a pregnancy. The vast majority of studies, however, have shown something very different, that AMH is very predictive of ovarian response, but not predictive of pregnancy. So once again, this may not be the right test to tell somebody you just are not going to get pregnant, or you must use an egg donor based on an AMH level. It implies a lower likelihood of conception, possibly, but more compromised ovarian response, and again, a need to just move along with things. So what are cutoff levels? Well, this has really varied from one lab to another. This study from 2010 suggested a level less than 0.9. 9 was suggestive of a poor response. But again, in this study, key point, what was the most predictive of pregnancy? Age. Is AMH helpful in younger patients? Well, this is a study that looked at oocyte donors, and it showed that the levels correlated with response, but again, nothing to do with the way embryos looked or cycle outcome. This is a question that we get asked a lot. If someone is on birth control pills and is just concerned about their fertility, can you measure an AMH level? And here the studies are kind of split down the middle. A series of papers have shown no impact. Other studies have shown that AMH levels are suppressed. So one way to look at this, if a patient is concerned about her fertility but doesn't want to come off her birth control pills, is to measure the AMH while she's on the pill. If the level is normal, you could only make the case that when she comes off the pill, it will be the same or better if she comes off the pill in the near future. On the other hand, if it's abnormal, it would then make sense that can have her come off the pill for one cycle and reassess. The opposite end of the spectrum has been the role of AMH as a part of the diagnostic criterion for polycystic ovary syndrome. So not really looking at this for ovarian reserve, but part of our standard diagnostic criterion, which have been the Rotterdam criteria, which, as you're aware, are ultrasound pattern of PCO, cycle irregularity, and or some degree of androgen excess, either clinical or biochemical. Well, what's interesting in this paper that came out in 2013, and using a very high AMH level of over 4.7, there is a high degree of sensitivity and specificity in diagnosing polycystic ovary syndrome. So saying women who had these high levels were more likely to meet the Rotterdam criterion. This is a little more complex slide, but this looked at all the PCOS presentations, which would be the morphology, hyperandrogenism, and oligoovulation. And the highest AMH levels, as you can see, were women who had all three criterion: ultrasound appearance, irregular cycles, and hyperandrogen state. Folks in the fourth group that had irregular cycles, hyperandrogen state, but normal morphology had the lowest levels, but they were still abnormally high, which would suggest that the hyperandrogenism had the least effect on AMH. But this could be very helpful in helping to predict, and there is a movement afoot to include this in the diagnostic criteria. So then there's another piece of the puzzle. What does this really predict? You know, I have patients that ask me, what does this ovarian reserve business really mean? So this gets to the question of, does abnormal ovarian reserve predict genetically abnormal eggs? Now, most of our data does not come from evaluating eggs, but evaluating pregnancy in embryos. So this is a paper from 2001 that showed that women with abnormal ovarian reserve had significantly higher pregnancy loss rates than women with normal ovarian reserve. Given that the majority of early pregnancy losses are chromosomally abnormal embryos, this would be at least suggestive of an increased incidence of abnormal embryos. So is there a relationship with true aneuploidy? Well, in '99, a paper by Nasseri and colleagues suggested that when FSH levels were elevated, this was a better predictive value than age for the incidence of chromosomally abnormal tissue from miscarriages. So this was not looking at eggs or embryos, but miscarriages. And then a more recent paper from 2000 showed that there was no difference in the incidence of aneuploid embryos when FSH was less than or greater than 10, but the way they were evaluating this was on probes that we no longer use anymore. They're looking at only 5 chromosomes. But it was interesting when you looked at women over 38 versus under 38, a much higher incidence of chromosomally abnormal embryos independent of FSH, which you would expect. However, this study is a little bit weak because they only looked at 5 chromosomes, and we have certainly gone well beyond that today. We had published a paper from CCRM in 2013, which looked at women who are undergoing comprehensive chromosomal screening of embryos and looked at ovarian reserve testing of FSH levels greater than 10 being abnormal and or AMH levels less than 1 being abnormal. And we compared this to women with normal ovarian reserve. So when we looked at the larger group as a whole, those that had abnormal ovarian reserve testing were much more likely to have chromosomally abnormal embryos. However, when we broke this down further into what was abnormal, the only group that had a higher incidence of abnormal embryos were those who had both an elevated FSH level and a low AMH level. The other 2 groups had similar incidence of genetically abnormal embryos. What's also fascinating is once we transferred a normal embryo, the likelihood of an ongoing pregnancy was no difference among these groups, which suggests that the problem has to do with aneuploid oocytes as opposed to anything else that could be associated with the agar embryo thereafter. So how do you compare all these tests? And there have been several studies that have compared one ovarian reserve test to another. This meta-analysis compared antral follicle count to the day 3 FSH levels. And the bottom line, unfortunately, is that both performed very poorly in predicting women who had not conceived. However, the antral follicle count was much more accurate than FSH in predicting response to medications. This paper looked at multiple studies. They looked at the impact of FSH, inhibin, and AMH, and they felt, again, they were all good predictors for women who weren't going to respond well. The AMH was certainly the most predictive of all of these, and that age, FSH, and AMH were most helpful in predicting response, but not helpful in predicting pregnancy. This paper compared AMH to antral follicle count, looked at 13 studies on AMH, 17 on antral follicle count. Both were basically the same in predicting poor response, performed well. Once again, both performed poorly in predicting pregnancy. So our approach at CCRM is that really value should be interpreted in light of the patient age. This is the critical piece. Please don't compare a 29-year-old with an abnormal FSH to a 40-year-old with abnormal FSH. She still has a good or reasonable potential for pregnancy. It really is comparing her to other women her age. If they've undergone treatment before, please look at their prior response. How have they done previously? And I think there's not just a single test that's going to be the most beneficial. I look at the FSH, the FSH to LH ratio, estradiol, AMH, and antral follicle all together in assessing not only the patient's prognosis, but when we get into things like in vitro fertilization and selecting an appropriate protocol. AMH and antral follicle count are the most helpful in predicting response. And I would say for your patients who are not yet attempting conception and are in their early 30s, it is a very reasonable approach to consider a fertility assessment. And this is something we do offer our patients, do offer your patients, which is to evaluate FSH, estradiol, AMH, antral follicle count in women who just want to know where they stand. It is important to understand that those levels are going to change over time, but allows them to know that they do have time to work with, or that the sand is running out of the hourglass a bit and they do need to move along more rapidly. And I think a patient's only going to thank their clinician for getting that information, even if the news is concerning. So I'd like to conclude this today by suggesting that all ovarian reserve tests have a better negative predictive value in older patients. They're better for older patients. Age is clearly an independent predictor, but you shouldn't look at the test results as absolutes. They can provide conflicting results. AMH and antral follicle count appear to be the most sensitive and predictive of response. The tests correlate, but do not accurately predict pregnancy or non-pregnancy. And remember this key point, that almost all the data we have comes from IVF patients, or certainly other patients going through infertility therapy, but there's not a lot of data for the general population. What's the benefit of urine reserve testing? It provides a realistic expectations of a response within the context of the age and past treatment. So it helps counsel your patients to give them realistic expectations. It helps select an appropriate ovulation induction protocol, and it helps you advise your patient of whether she should be put on a fast track for more aggressive fertility care. Well, I think the best summary comes from H.L. Mencken, who was a critic from the Baltimore Sun in the 1920s, who said that there's a simple solution to every problem, and it's usually wrong. So sometimes it has to be a little more complex. Well, I very much appreciate your putting up with us today, and I know that there's been some glitches, but I appreciate your attention, your support in the past, and hopefully the future. And I'd be delighted to answer any questions that you have. So just type them in, and I will be happy to respond. And this also, as Kelly will tell you, will be spiffed up a little bit and then put up on the website as well. And she'll be able to provide access to you to review this in the future.
Yeah, that's right, Dr. Suri. We can send out a PDF of your slides so that people can view them more clearly, obviously. And we do again apologize for the technical difficulties. It seems that the actual webinar website is updating tomorrow. They have had some glitches, so it could be an issue on their end, unfortunately, that affected us. And we can send out the slides for your review again by email, so you can review all of these. As of right now, we don't have any questions, but we can wait a couple more minutes. But again, I do apologize for the technical difficulties. And
we will plan on having another webinar scheduled over in the next quarter, and we'll certainly send out information in that regard. And thank you, Katie, for your comment, and we will continue this in the future. And we'll send out a poll to all of you of subjects that you would like to have included as well.
Okay, well, I believe we don't have any more questions at this time. You sure can email. You can email KStude, that's KSTUDE at COLOCRM.com if you have any further questions. But at this time, we will conclude the broadcast.